And shade consists of three elements. Hue, which is the main ID, which affected and by wavelength. Chroma is the intensity of this color. Like we have pink and we have violet. They both are derivatives of red color. And the value. Value is the lightness of this shade, of this what we see. And in dentistry, it's the most important factor. This overall called Mansell color system. And this is what we use every day. For better understanding, we have this color picker, we have the hue. At every level of a hue, we have a chroma, which change and we have value. We use it in dentistry every day. Like we have 3D Master. 3D Master Shade Guide from Vetta. We choose the shade according to value first, and this change according to chroma, and the list and the final stage of color choose is hue change. So the challenge in dentistry is how to mimic natural tooth of the teeth with something artificial. This artificial object have different optical behavior. This artificial, as we talk, it has it has different optical behavior. This optical behavior is it get affected with many factors, mainly with underlying structure, and this interaction due to crystalline content. What, in other words, it's the composition. It's affected the thickness of this material. This thickness determinant factor. It's affected to opacifier. Opacifier is filler. It change from material to other in shape. It change in distribution. It change in of origin. It's affected with translucency. Companies provide every shade with sometimes some shade with high translucency, low. We have enamel, and the last interaction due to shade change. So, optical effects. We have to understand there is two types of this optical effect. We have to differ between shade changing and background. This two interaction of these two change, there is an equation to evaluate. There is a perception level, but we're not here to talk about this. We're talking about, in same simple words, when we want to evaluate shade change according to some factor, we evaluate this shade without this factor and this shade in the presence of this factor. So, the more change we have between shade A and B in absence and in presence of this factor, that means this factor causes more effect. Background masking, according to ISO, background masking is related to translucency. But in dentistry, it's difficult to evaluate because according to ISO, we have to evaluate translucency of ceramic with thickness 0.3 to dark background. In dentistry, we don't always use like crowns or veneers with 0.3 thickness. And that's first thing. Second thing, we don't have just dark background. We had high chromatic background like A3 shade. We had low chromatic but low value background like tooth shaded C1 or C2. So the best way to evaluate background masking is to evaluate shade change between complex restoration resin and abutment shade which control like maybe A1 and the abutment I want or the shade I want to mask. Like I'm evaluating if I'm able to mask shade A3. So I have to find the easy way and the better way. I have to find the shade change between shade control shade like A1 or maybe bleach 4 and A3 shade. The resin cement, we have too many shades of resin cement, but we have 4 main categories available in all resin cement company or systems. We have opaque, we have translucent shade, we have universal shade A or tooth shaded A1, and we have universal shade A3 or tooth shaded A3. Actually, tooth shaded A3, it's not opaque, not always opaque. Sometimes it's translucent, not completely, but its effect on the final restoration because of its chroma, not because its value, not because it's dark, because it's high chromatic. So it's changed the chroma, it's changed the chroma of the restoration. They are same label, but doesn't cause the same effect. And that because of composition and effect of two shaded cement. What we mean, not all opaque cements will cause the same effect on the restoration, but the majority of this opaque cement will cause that. We'll evaluate this effect according to ceramic classification. Okay. First of all, for glass matrix ceramic, we'll focus on 4 shaded of glass ceramic, which is translucent, opaque, A1 and A3. When we choose opaque shade of glass ceramic, we found there was no effect of the resin cement of this at 2 thickness, 0.5 and 1 millimeter, except for A3 cement at 0.5. And here's that question. If I'm doing veneer with opaque shade or bleach, why to use A3 resin cement? And the answer that, first of all, maybe I think it's opaque, so it will shade it. And second thing, maybe the doctor noticed that it's very whitey, so I want to decrease this whiteness. So if I use A3, it will be less whitey, it will be better. No, it caused darken shade. It caused change, and we need to replace. For translucent shade of ceramic material, glass matrix ceramic, is very affected with all of resin except for translucent shade. All the resin caused unaccepted shade change for this ceramic. So, except for translucent shade resin. So, what we mean here, when we choose to use translucent shade, that means I don't need to shade any background color. It's just for modification of the shape. A3 was affected with opaque resin cement and A3 resin cement. And A3 was affected with opaque resin cement and A3 resin cement. The conclusion that glass ceramic or glass matrix ceramics are affected mainly with high value resin cement and very high value resin cement and very low value resin cement, which is opaque and A3. For zirconia ceramic, I want to subdivide zirconia ceramic to high translucent monolithic and all other type of zirconia ceramic, because zirconia is very good, has very good opacity. Unfortunately, translucent ceramic or translucent zirconia ceramic is affected with resin cement at any thickness, and it's unaccepted shade change. Even at 1.5 or 2 millimeter, it was affected, but it was at accepted clinical level. Last thing, resin matrix ceramic. Resin matrix ceramic are new. It start in commercial from 6 or 8 years. They are organic matrix in origin, but are high filled with ceramic particle, just filling. They were developed because we need material more resemble to tooth in module of elasticity, and we need material we can repair. Commercially, it's available just in tooth shade. There's no from A1, A2, B1 maybe, but there's no translucent, no opaque shade. So it was not affected. It was not affected with resin cement at any thickness. What mean? The shade we see and before cementation is the same we see after cementation, except for A3, which cause unaccepted shade change. Last thing, we have to talk about tray in cement. Tray in cement is provided by some manufacturer. It has same shade of the resin cement. We had very good agreement between resin cement and tray in base, except for some papers stated that just opaque cement doesn't has good agreement between tray in base and resin cement. In the end, I want to thank everyone. I want to thank my professors, Dr. Mazen, Dr. Faisal, and Dr. Jed. And thank you.